So the next 20 minutes we're going to talk about change management, as has been the theme of the morning, and I'm going to share with you some of our learnings from what we call the Enhanced Nurse Clinics project. So probably a similar situation to most people here in the room is we had a project and we had to go out and encourage health services to change. So what we'll do is run through some of the common themes and challenges, and I'm sure some of them have already been discussed, but some of them will be very familiar to you. I'll try not to talk quickly, I'm feeling the time pressure. So we had a 3-year government project or program of activity, and one of those projects was the Enhanced Nurse Clinics projects, and this is our lovely contractual aims. I think simply put, what we wanted to do was enhance the role of nurses in care delivery. And probably a part of practice support or part of your projects of activity, we wanted to simplify the aim and going, well, how do we enhance the role? How do we put the nurse back into care delivery? And what do we want to achieve at the end of that? Well, we actually wanted to document what we learnt and share it with others. So we had to come up with a project structure. We needed to implement this project. You can see up there the details. We recruited 11 health services. We worked with them for 2 years. They did receive some grant funding to do this work. We asked each health service to nominate a lead nurse who would undertake the project activity. We gave them education and training. We used the model for improvement. There was dedicated support, site visits and evaluation. So what did these clinics look like? Well, as you can see, they were from a range of primary healthcare areas, mainly general practice. We had correctional care, community and aged care. You'll also note there as well, there's a range of model types. So from wound clinics to teen mental health clinics, men's health, hepatitis. So a range of models of care there. And you have to remember at the beginning of the 2 years, the practices or health services came to us and said, we want the nurse to do more. We want to change the way we deliver care. And this is where we ended up with them. I also want to make a note here on language, because I think language is really important. While we refer to the project as Enhanced Nurse Clinics, the reality of the care delivery is that it is team-based care. There is active involvement in all of these clinic models of the general practitioner and also other health professionals. It's a nuance when we started the program that Enhanced Nurse Clinics was meaningful to our primary healthcare nurses, and that was a great hook in trying to advertise a project, and I'm sure that's something as PHN teams that you have to think about language, you have to think about how you engage with your practices and the practice staff. So I think we'll look to evolve that as we move and team-based care becomes a bit more common language. But 2-3 years ago, Enhanced Nurse Clinics was the better hook for us. I'll quickly run through some of these clinics so you've got a picture of what they look like at the end. Bega Valley in New South Wales, they actually had a range of teen suicides in the area, and what they realised is that teens were having a hard time and struggling to access care. So through their participation in the program, they set up a teen drop-in clinic. So this is a nurse-led service where young people attend for STI screening, contraception, relationship advice and mental health issues. Teenagers are assessed and triaged by the nurse and referred to a general practitioner or other health professional on that same day. We have a wound care clinic where again the local need was the health service was finding that patients weren't following up, they were hesitant about seeing wound specialists. So they could see there was a need and they implemented a nurse-led wound clinic where the nurse sees the patient for 30 minutes and due to our activity-based funding model, the GP pops in and also sees the nurse sees the patient, as required. And we also had Ballarat Community Health. So what happened here is the lead nurse worked with the local geriatrician, and what they did is updated their model of care for patients with dementia. So this introduced nurse-led care planning and coordination, this is a great example of really how the nurse and GP sat down together and talked about roles. They talked about They had that one-on-one communication about their different roles and responsibilities. Okay. So this is probably the crux of our change management. So I just want to reflect and share with you our enablers and barriers, and again, I think they're going to be quite common to what you've experienced. I'll give you an insight into some of the things we did, but as you all know, change is really complex. You know, the model for improvement's not going to solve it. Communications helps, but there's no one thing that's going to solve it. So it's a combination of activities, and one activity that works for one general practice or health service guaranteed won't work for the next. I can see people nodding. So enablers are something that allows or permits. So let's jump into our enablers. So the first thing we found was that the enablers changed depending on the stage of the project. So initially when we were recruiting and bringing on these health services, what we found was that awareness and inspiration was really key to engaging people in change. And what we mean by this is they had to be interested or excited about the idea of changing their care delivery. They needed to know that it was possible. And to do that, we actually needed to talk through practical examples. We needed to talk about different types of wound clinics. We needed to talk about, drop-in clinics. And we needed actually to talk about it in really practical terms so people could see and be aware and go, okay, well, I think we could do that. We also needed at least some willingness to change. I think it's naive to think you'll go into a health service and everyone's so happy to see you, you know, you're welcomed in the door and they want to hear about your project or change effort. So with the willingness to change, we said to the lead nurses and we said to the health service, look, at the early stage, just an openness or somebody willing to listen to you, that's a good starting point. And you know what? Some people won't listen to you as well. Also, I think we have to recognise that, you know, MBS has been around for a while, this GP engaging primarily with the patient, this is really embedded systems and cultural activity. So I think we were really mindful on how challenging this is for general practitioners and actually how we're asking them to share the patient interaction with the nurse. And, you know, while we talk about it and we go, oh, okay, well, it should be simple and it's obvious, this could be 30, 40, 50 years of behaviour that we can't expect people to change overnight. They've been doing it for so long. And their value is attached to that patient interaction. And we know the nurse can add a lot, but we have to be mindful of that and the time it takes to get to that place. Another need was relevant local health need. Again, this is interesting. We know collecting data within health services can be difficult. So when the health services came on board to the project, we said to them to think about their local health need. And we kind of said, you know, if there is a need, the patients will come. But the key challenge was it an observational need or where was the actual demonstration in the need? So one health service came to us and said, oh, we think we really need to do something in refugee health. And we said, great, let's look at the data. How many patients do you have that you'll see that will come to the clinic? When they looked at the data, they had a really small number. It actually wasn't worth the effort for the small number of refugee patients they had. So I think they ended up, I'm not sure if that was the wound clinic or another clinic, but they had to look at their data. They had to look at their critical mass. Bega, the local health need was, you know, the local youths were at risk. The community was behind the general practice. They worked with the high school. There was a need and people wanted to engage. And then for us, comprehensive information. So for APNA as a support organisation, and we were a bit like graceful swans at the beginning, is we needed to be a touch point for these health services. And I think this, more so for PHNs, you're expected to know everything and you want to be there to support them. So when they would call and say, well, how would we do in a recall system for, you know, wound care, or what sort of appointment do we do it on a Friday afternoon or a Monday? We had to have that information on hand. So at the beginning, as we were learning as well, we were only probably one step ahead sometimes of the health services, but we had to rely on the team internally within APNA. There was lots of discussions, lots of research. We had to find those nurses that were doing it in other areas. So lots of collaboration and engagement, because To help people change, they want to see it, they want to hear it, they want examples. And that was up to us to come up with those examples. Okay, so some more enablers. So as we moved away from the awareness, the inspiration, thinking, yes, we can do something here, we moved on to implementation, which came with its own set of challenges, but also enablers there that were important. Firstly, we found project management skills was a key enabler for implementation. We had to work with the lead nurses on mapping out their model of care. So having the view, having the picture, how do they break down the activity? What are you going to do first? Are you going to look at the rooms and equipment, or are you going to do clinical training and upskilling so you can deliver the care? So once we had mapped out a bit of a project plan with the lead nurses, communication and engagement was key. One thing we did when training on communication engagement, we also trained on resilience. That you have your plan, you're excited, you're talking to the admin, and the last thing they want to hear about is, I'm going to have to book an appointment differently for this situation, and that's hard work. And I think you need to prepare those people you're working with in health services that they're probably going to get a lot of no's, they're going to get a lot of eye rolling, they're going to get, we've done this before, it's not going to work. And you have to build resilience in them, or in yourself if you're going in to the health service, to talk to that and to recognise those frustrations. So for us, communication and engagement, but then also directly with that is training on resilience. We also found the authority to make decisions. So in this situation, we're working with lead nurses. So, in some health services, the principal has the key authority, or the practice manager. So we had to initiate and ensure some delegation of authority so the nurse could engage with the team. So the nurse could say, yes, I'm booking this room on Friday morning, or I'm actually going to take some protected time to do some planning. So sometimes we found we had to step in and do that. And the leverage we had to do that is that this was a program the health service had signed on to. So your leverage could be nothing at all, or you could have a service agreement where there's a commitment the health service makes when signing on to the project. Funding was a key enabler, and I'll talk to that a bit further in a minute. You would have seen in my project's structure that we did provide grant funding, but it wasn't enough to cover 2 years of income and have the nurse work on their clinics. So we had to make MBS work. So these are, again, they're not healthcare homes practices, these are practices changing care delivery, working team-based care within the current MBS model. And I'm sure most people, there's nuances. You can make it work, and people make it work in different ways. And also another key enabler, which I think we sometimes forget and assume, is clinical upskilling. So ensuring that the nurse, and if they're taking a more active role in care delivery, is they have the appropriate skills to do that. And that's what also some of the grant funding was for, was clinical training for the lead nurse. Barriers. So if an enabler permits, a barrier prevents and disempowers. So I've only got one slide on this because I think it's a given that, your barriers and enablers are yin and yang. So if you look at your enablers and then think of the opposite, they're obviously key barriers. But what I wanted to draw your attention to in our situation was the lack of understanding. And if we get a chance, I'd be interested in your perspective, is from a APNA's base, we see that there's still a gap between people understanding what nurses can do and what nurses can add to the patient interaction and care delivery. And some of that is limited by MBS. Lack of protected time. Time is such a valuable commodity in general practice. It's the GPs, it's the admin, it's everyone's time. And that is driven by MBS, activity-based funding. And it was really sad to hear, and we heard it a number of times through the program, is that nurses described feeling guilty taking protected time to work on planning for evidence-based care. And I think it's something, again, you guys will see, but it's a reflection of the system we're in. And it's a great thing about the healthcare homes is if we work to change that. But if you actually think about that, even as a patient, you go, people are feeling guilty about planning for evidence-based care. As I said, we did MBS, again, another barrier, but we made MBS work as much as possible. And I'm not going to say all these clinics broke even or generated income. Some didn't. The bigger model, where in situations a GP won't see a patient, the clinic accepts that they make a loss on that interaction because they don't privately bill, it's a need for the community, and they offset that. But that's not appropriate for every health service. Their needs, motivations are very different. The other thing which I think is a reality is workforce capacity. We had some really rural and remote health services in the program. And what we found is if they lose some of their workforce capacity, so if they lose a nurse or a doctor, they shift from day-to-day activity to survival mode. And I'm sure you've all seen it. And it literally is survival mode. They can't meet that acute demand that's coming in the door. And what can we do as project people? We actually can only support them and listen to them. Like having this unrealistic expectation that they will do more and more when they're losing staff, they're in survival mode. So it's a barrier, I think, due to the nature of Australia being huge, and we have to accept in some ways because there is a workforce capacity issue as well. Lack of team support and also access to clinical data. I was surprised to see that some of our nurses weren't able to access their clinical data. They weren't given delegation to access PHN. And again, this is a reflection of the types of health services we're working with. Some are great, fantastic. Some, it is really hard. And you're talking to them, we're talking to them, and you can see a difference. The data, the feedback they can get from, okay, well, this is my patient population, this is how many I've seen. Data is really important. Oh, got 10 minutes left, so I'll probably talk to this slide and then quickly rush through my last ones. Throughout this period, we had coming up to 2.5 years now working with these health services, we noted some system-level themes that impacted our work directly, so great learnings for us, but also I think that would impact a broader rollout of this work. And the first is nurses can't do it alone. We were working with a consultant who hadn't worked in health, and he said that to us, and it just really rang true to us, because what we were doing in the program, and I'm sure the team out here have done it as well, is there's an underlying expectation in some of this work that is implicit. It's implicitly implied that the nurse will convince the doctor, the nurse will come up with the business model, the nurse will create a business plan, will understand MBS, will do a budget, will do all the team communication, will undertake the training in the appointment system and all the other things, and also perform their other day-to-day duties. So we really, as much as we were working with the lead nurse and the project structure was the reality we could only target one person, but they couldn't do it all. And we were asking them to do it all. And to their credit, a lot of them did do it all. But is that sustainable for system-level change? Not at all. So I actually feel a bit guilty now. I had never looked, it was just always focused on how do we get the change, and we had willing and engaged lead nurses who were willing to do this. But when you think about it at a system level, it takes a village. So one of the key changes for APNA now is, this project was about getting behind nurses, skilling them, upskilling them. What we want to do as an organisation now is get in front of nurses. We want to get in front, we want to talk to the GPs, practice managers, and try and have that village, try and at least build some capacity where we're not just asking the nurse to do it all. Funding influences everything. It's the last question, and it's the key concern, and we have to recognise it. We have to work until we get evaluation, until we move to that healthcare home environment. If we want to do change now, we have to recognise MBS, and we've got fact sheets on it now in relation to these clinics. We have to share that information. The other great thing is make it practical. As project people, we love writing reports, we love our big explanations and introductions. The nurses said to us, no, just make it deeply practical advice, checklists, examples, tell us what to do. They find a lot of the information is just too long, it's frustrating. So we need to make it snappy. That became a bit of our catch cry in the project. Make it snappy. Dot points, checklists. If it's over 3 pages, does it need to be? So deeply, deeply practical advice. The other thing we found, which again I think is a common habit we get to in project work, is clinics are similar but unique. And what we do is we say, here's a great model to use, and we think that everyone can implement that model. And why we found there are characteristics in nurse clinics that everyone shares, the exact form they take is actually so dependent on their local context. So in developing resources and saying how can we get other health services to implement this type of care, we had to come up with what we call a modular flexible approach. And then finally, this is another system level change that APNA and government and PHNs need to take on board, is perceptions need to shift. Current perceptions of nurses and the potential of nurses involved in care is a key challenge for system level change. So, as I said, the outcome and what we wanted to do was develop a heap of resources. Now, all of these are on our website, so I'll give you the link. So what we came up with is the 8 elements for implementing enhanced nurse clinics or team-based care. These are meant to provide a flexible approach, and they're practical. So everyone generally starts with a plan, but if you look at location and facilities, talk to people about the space. What room are you going to use? When is that room available? Staffing and HR. Do you need professional development? What relationships do you have to build in and out of the practice? You've got there your evidence-based care. So what are the standards you're working to at the moment? Appointment systems. Again, when you get to the nitty-gritty, you go, yeah, how are we going to make that appointment system work? How are we going to make that work with medical director practice off? Promotion of the clinic. Are you going to do a poster in the waiting room? So really practically based things. This is some of the resources we have on the website, and this is to demonstrate that every clinic's similar but different. So this is the clinic process flow. So this is how they went about setting up their clinic. You'll note the first kind of 3, I won't waste time. So here, everyone generally starts with a clear plan, but the next step for them was location and facilities. Then they wanted to look at funding, and then they moved on to their systems and processes. For this next health service, again, they started with their plan, but their next step is they looked at best practice care, patient engagement, and then funding. So what we wanted to do with these resources is not say this is how everyone does it, but these are the elements you need to think of. And also the way you approach those elements will be different, and the level of detail you go into with each of those elements will be different. Again, we've got nurse clinics, so heaps of, please use them in your role PHN. Send them, put them in your newsletters, send them out to your health services. There's case studies, templates. We think it's snappy, but it's probably not as snappy as it can be. So give us any feedback. If you find that resources are working well, or there's templates, we'd love to hear it. Healthcare homes readiness. So from APNA's perspective, we've built up a really, what we think is a wealth of knowledge and in the application of changing care delivery. So we've now started working with PHNs and are doing training with nurses, and we're also inviting practice managers to the one day where we're going through the elements of changing care delivery, of team-based care. And again, making it practical, making it snappy, making it within the current, so this is healthcare readiness, it's not, the trial sites, but with those that are preparing for what I call the New World Order, they can start changing care delivery now and within the current system. Is it going to be easy? No. But it actually can happen, and we've got examples and we've now got resources. And this lines, that transition into healthcare homes where team-based care is a key element of high-performing teams. I feel like I rushed, but I got through it all. So any questions or comments? There's probably about 2 minutes. I'll repeat the question or... Oh.
Just on the last point that you made about APNA having resources and speaking with PHNs and that. Are they free resources or?
Yep, so all of these resources are on the website. So see these are PDF documents.
Yeah.
It's got details, there's templates. So all of our resources completely available.
Did I misunderstand it or?
In regards to training, there's
training.
there's obviously costs in getting the APNA team to locations and time out of practice. So, we just work with PHNs there in regards to that.
And look, I understand you've got to put a value on things, but when you work for non-for-profit organisations and they don't see the value and you fight for everything, if I could just say, when you're looking at charging, can you keep the costs down? Because it's really hard.
Yeah.
And often we find that the nurses, and please, we have to pay for it ourselves. The practices or the PHN won't pay for us to do these things. Yeah. And it's expensive and we don't get paid enough to afford some of these things. So it's a real issue.
Absolutely. Yeah, and I think we appreciate that. APNA as an organisation, we're not looking to make profit on this, it's just cost recovery because, and one thing we can look at the future is things like webinars where we're doing programs. There are other different options we can do. There's APNA organisational membership where we have nurse support. So that's still a cost, but it's a lower cost. So we appreciate, funding for professional development is a challenge, and it's a challenge for us as an organisation as well. So look, let's have the conversation. At least we can direct you what's free, and then we keep in mind if we know free things are coming up, we can communicate. Yeah.
Alison, can you tell us a little bit about the evaluation of the clinics? Was it externally evaluated, and is there any plan to maybe look at an evaluation a few, years down the track of some of these clinics for hospital prevention or along those lines?
So what we talked about to date is we evaluated with the purpose of developing resources. So that was very much practical project implementation evaluation. What we've also done is we have an independent evaluation undergoing. Some of these clinics have been, by the time you do your planning and your lead-in, they've been running for about 12 months. So we are trying to collect some data and undertaking some independent evaluation. So we're hoping we'll have some of those results to share around July. Beautiful. That's all right. I think we're a minute past lunchtime, so I might hand back to Mel.
So just really quickly, oops, I'm going to get in trouble, in talking about that, this is a brilliant forum. Is everyone here part of the PHN Network group that APNA lead? Yeah, so if you're not, have a chat to Murphy Wood. Murphy heads that up. That's a fantastic forum for all of us to tap into, I guess, in work time. That's when they're usually at lunchtime or for an hour or so. And that's a forum for us to all share information across the nation and what we're doing in our own PHNs and how, I guess the challenges we face, because we're not alone, but sometimes when you verbalise those challenges, you just work out or listen to how other PHNs are dealing with them. It's a really powerful platform. In addition to that, with an APNA hat on, we absolutely value the relationship that we have with PHNs with a sincere understanding that you have such a valuable touch point to our members, and we want our relationship to grow and develop, knowing that the messages that you have that ability and the power to get our key messages out there and support our members, with our assistance. So certainly tap into the fabulous office staff and the work that has been done. There's some really powerful tools there that can be utilised.